Hi everyone, welcome to the CAD-ACS video. CAD stands for coronary artery disease. The heart is basically just a big lump of muscle and it has its own blood supply via the coronary arteries. CAD is when the blood vessel supplying the heart with blood becomes diseased with atherosclerotic plaques. Here's a diagram of a normal artery that's nicely opened and patent, allowing the blood to flow freely. And here's a diagram of a diseased artery with plaque buildup on its walls. The lumen or the opening is a lot more narrower in comparison and blood isn't able to flow as well. We used to think of atherosclerosis as layers of plaque building up on the vessel walls, kind of like a painter painting over the walls, but now we know that the process is a lot more complex than that. So what exactly is plaque? Plaque is the result of years and years of a repeated inflammatory process that begins with cholesterol. Here we see a cross-section of plaque which shows a fibrous cap and the necrotic center. This will be the lumen where blood is flowing, and this will be the basement membrane of the blood vessel. The fibrous cap is made up of smooth muscle cells, macrophages, lymphocytes, and collagen. And the necrotic center is made up of smooth muscle cells, macrophages, foam cells, lymphocytes, cholesterol crystals, calcium, and cell debris. I just think of the necrotic center as fatty junk. Let's talk about foam cells really quick. Foam cells are macrophages that localize to fatty deposits in the bloodstream. They ingest LDL or low-density lipoproteins and become filled with lipids, giving them a foamy appearance under the microscope. So you can just think of them as white blood cells that ate a whole bunch of fat. So how does plaque grow? Over years and years and years. That's why patients with CAD tend to be older, in their 60s, 70s, and beyond. Atherogenic factors or risk factors for developing CAD include hypertension, diabetes, hyperlipidemia, tobacco use, and obesity, as well as a family history of CAD. Just really quick, if you ever heard of how there are good and bad cholesterol, LDL is the bad cholesterol and HDL is the good cholesterol. LDL stands for low-density lipoproteins, and HDL stands for high-density lipoproteins. There's also VLDL, which stands for very low-density lipoproteins, and those are considered to be a bad cholesterol as well. The mechanism of plaque buildup isn't yet exactly understood, but it's believed that oxidation of LDLs is thought to be the inciting factor. Cholesterol from the blood can seep into the endothelium of the blood vessels, which will attract monocytes. These monocytes become macrophages, which ingest the cholesterol. Then they become foam cells, which contribute to development of the lipid core, and over time cells die, they become calcified, and eventually form the necrotic center. So it's less of a painter painting over the walls and more of an inflammatory process that happens again and again over the years. So there are two types of plaque. There are stable plaques and there are unstable plaques. Stable plaques have a thick fibrous cap with a small and hard necrotic center, and unstable plaques have a thin fibrous cap with a large and soft necrotic center. Plaque buildup can significantly narrow the blood vessels, but the true danger of plaques is that over time the fibrous cap of the plaque can erode and rupture, releasing the contents of the necrotic core into the bloodstream. Remember what the necrotic core was made out of? It was basically a whole bunch of old and dead cells and calcified fatty deposits. When this gets released into the bloodstream, your immune system switches on, activating a whole cascade of tissue factors and coagulation factors that recruit various inflammatory cells and platelets. Ultimately, a thrombus or a blood clot will form. Sometimes the blood clot is kind of on the smaller side, and there is still some room for the blood to flow by. Partial occlusions like this is what's typically happening in an NSTEMI or a non-ST elevated myocardial infarction. But sometimes the blood clot is big enough where it totally stops the blood from flowing. Complete occlusions like this is what's happening in a STEMI or a ST elevated myocardial infarction. So the names STEMI and NSTEMI comes from whether or not there is elevation of the ST segment on the EKG. The EKG allows us to look at the electrical activity of the heart. So here's what a normal heartbeat looks like on an EKG. The P wave is when the atria or the top two chambers of the heart squeezes. Then there's a little pause after the P wave, which allows the ventricles to fill up with blood. The QRS complex is when the ventricles or the bottom two chambers of the heart squeezes. The right ventricle pumps blood to the lungs, and the left ventricle pumps blood to the rest of the body. The T wave is when the heart repolarizes, getting reset for the next heartbeat. When a plaque ruptures and causes complete occlusion of an artery, we see elevation of the ST segment on the EKG, so we call this a STEMI. ST elevated myocardial infarction. It's a bit morbid, but a way to remember them is that they look like little tombstones. STEMIs require emergent intervention, meaning they have to go to the cath lab right away. When there's partial occlusion of a coronary artery, we tend to see ST depressions or T wave inversions where the T wave is flipped upside down. Since the ST segment is not elevated, we call these an NSTEMI, non-ST elevated myocardial infarction. In an NSTEMI, the restriction of blood flow causes a mismatch between the demand and supply. This results in ischemia, and if left untreated, will progress to infarction where cardiac muscles will begin to die. NSTEMI is still a heart attack, and although it may not require emergent intervention like a STEMI, it requires urgent intervention. Typically, NSTEMI patients will be admitted to the hospital and taken to the cath lab later in the day or within the next few days. When a patient comes to the ED complaining of chest pain, what's one of the medications that we like to give to them? And this is something we can give to the patient even before any labs or imaging studies have been done. So we like to give the patients aspirin when they're coming in with chest pain. One of the effects of aspirin is that it acts as an anticoagulant, so it prevents blood from clotting. Even though we may not have any idea why the patient is having chest pain, the upsides of preemptively treating with aspirin are pretty significant in case the patient's symptoms are due to an acute coronary occlusion. If the patient ruptured a plaque in one of their coronary arteries, aspirin can help in preventing a large blood clot from forming. But if the patient is having chest pain due to other reasons, side effects of aspirin are pretty benign and won't cause too much harm. A full dose of aspirin is 325 milligrams, and a baby or a low-dose aspirin is 81 milligrams. This is why we sometimes give 3 additional baby aspirins to patients who are having chest pains. Let's say a patient takes a baby aspirin every day. They took one this morning as usual, and then in the afternoon began to develop chest pain. The pain was severe enough that they called 911, and when the EMS arrived, they gave 3 additional baby aspirin, because 81 times 4 is 324, and that's close enough to the full dose of 325 milligrams. But what about nitroglycerin? Nitroglycerin is another medication typically given sublingually that we can give to patients when they're having chest pains. It works a little bit differently than aspirin, as nitroglycerin is a vasodilator. It causes the arteries to relax and expand, allowing more blood to flow through. So aside from giving patients an aspirin and/or a nitroglycerin, what's one of the first things we want to obtain when a patient comes into the ED complaining of chest pain? An EKG. The reason is that we want to identify STEMIs as quickly as possible. So let's dive a little bit into EKGs. EKGs measure the electrical activity of the heart. More specifically, we're measuring the depolarization and repolarization of the cardiac muscle. It can be a little bit confusing, but this is not the same as the heart's electrical conduction system. The heart's electrical conduction system starts with the SA node, or the sinoatrial node. This is the pacemaker of the heart, which starts the heartbeat. The signal causes the atria to contract and moves onto the AV node, or the atrioventricular node. At the AV node, there's a slight pause, allowing the ventricles to fill up with blood from the atria. The signals from the AV node then travels down the bundle of His, splits into the right and the left bundle branches, and into the Purkinje fibers, which ultimately causes the ventricles to contract. The activity of the heart's electrical conduction system is far too small to be picked up on the skin surface with the EKG machine. So what we're actually measuring is the electrical activity of the heart muscle itself. Think back to your biology class when you learned about action potentials. Remember learning about the sodium and potassium ATPase, how it pumps sodium and potassium ions to create a negative membrane potential? Remember learning about the all or none response, how sodium and calcium channels open, causing an influx that depolarizes the membrane, making everything positive? Then the potassium channels open, causing repolarization and making everything negative again. It's these action potentials that are causing the cardiac muscles to contract and the heart to beat. It's these action potentials that we're picking up on the EKG. Here's a diagram that shows the differently shaped action potentials of different parts of the heart. All of these action potentials add up to create what we see as the heartbeat on the EKG. Again, the activity of the heart's electrical conduction system is too small to be picked up on the EKG. That's why the action potential of the SA node doesn't contribute to the EKG. The AV node just shows up as a pause, and conduction down the Purkinje fibers doesn't show up on the EKG either. Depolarization of the atria shows up as a P waves. Depolarization of the ventricle shows up as a QRS complex, and repolarization of the ventricle shows up as a T wave. If you're wondering about the repolarization of the atria, it's there but not visible since it gets buried in the QRS complex. It makes sense that the QRS complex is much larger than the P wave. Since the atria just pumps blood to the ventricles, they're not very muscular, so not much electrical activity is picked up from there. In contrast, the ventricles have to do a lot more work, especially the left ventricle, so they're much bigger and muscular, which means much more electrical activity will be picked up from those areas. Here's a little animation of the conduction system and how it correlates with the EKG. By the way, if you're wondering why the T wave, which represents repolarization, appears as an upward deflection on the EKG, it's because repolarization of the ventricles occur in a backwards direction. Now let's talk about how the EKG machine works. The EKG machine uses multiple electrodes to measure voltage. For a 12-lead EKG, there are 10 electrodes that get placed on the body. One goes on your right arm, one on your left arm, one on your right leg, and one on your left leg. The electrode on your right leg is the ground, and then 6 more electrodes get placed on your chest around the heart. This results in 3 limb leads, 3 augmented limb leads, and 6 precordial leads, which make up the 12-lead EKG. The limb leads are named 1, 2, and 3 in Roman numerals. The augmented limb leads are named AVR, AVL, and AVF, and the precordial leads are named V1 through V6. Remember in physics how you learned about measuring voltage? You take a positive and a negative electrode, and you're just measuring the difference between the two. That's basically what you're doing with the EKG, and for a 12-lead EKG, you can think of it as taking different measurements at 12 different places. More accurately, we're measuring the electrical activity of the heart from 12 different angles. In lead 1, we're looking at the heart from the left. In lead 2, we're looking at the heart from the bottom left. And in lead 3, we're looking at the heart from the bottom right. With AVR, we're looking at the heart from the top right. AVL, we're looking at the heart from the top left. And AVF, we're looking at the heart from the bottom. In the precordial leads, V1 through V6, we're kind of doing a panorama of the heart, starting from the front of the heart at V1 and moving around to the left side of the heart at V6. So this is probably what most of you are picturing when you think of an EKG. This is a 12-lead EKG, and we can count all the leads. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Again, the 12 leads are made up of the 3 limb leads, 1, 2, and 3, 3 augmented limb leads, AVR, AVL, AVF, and the 6 precordial leads, V1 through V6. On the grid paper that the EKG is printed on, x-axis represents the time and y-axis represents voltage. So the taller and deeper the peaks are, the larger the depolarization or repolarization that was picked up on the EKG. It's pretty typical to see lead 2 along the bottom of the EKG. This means we were looking at the heart from the view of the lead 2 for a longer period of time than the other leads. Since the left ventricle does most of the work and is the most muscular, it also has the most electrical activity. This causes the overall axis of the depolarization to be pointed from the right atrium to the left ventricle. This means lead 2, which is looking at the heart from the bottom left, gives us the best view of the heart in terms of its electrical activity. Certain leads can be grouped together based on the angle that they're looking at the heart. Lead 2, 3, and AVF are referred as the inferior leads because they look at the heart from the bottom. Lead V1 and V2 are called septal leads because they look at the septum of the heart, which separates the right side from the left. V3 and V4 are called anterior leads, and V1 through V4 are typically grouped together as the anteroseptal leads. Lead 1, AVL, V5, V6 are called the lateral leads because they look at the heart from the lateral aspect of the heart on the left side. And AVR is kind of left alone doing its own thing because AVR is just looking at the right atrium where there isn't a whole lot happening. On the EKG, you can see the different distributions of these leads and how it can help clinicians figure out what's going on with the patient. For example, if you see an abnormality in lead 2, 3, and AVF, you may suspect there is something funky going on the inferior aspect of the heart. If you see something odd in lead 1, AVL, V5, and V6, you might suspect something on the lateral side of the heart. Because different coronary arteries supply blood to different areas of the heart, we can also correlate different leads that are looking at different sections of the heart to those coronary arteries. For example, if you see ST elevations in the anteroseptal leads, which were lead V1 through V4, you may suspect there's STEMI going on and a complete occlusion of the LAD. Or let's say you're seeing T-wave inversions in lead 2, 3, and AVF. Now you're suspecting partial occlusion or NSTEMI in the area of the heart that's supplied by the RCA or the left circumflex. By the way, the LAD is referred to as the widowmaker artery. It provides majority of the blood flow to the left ventricle, and a large occlusion in the LAD can lead to sudden death. Here we can see the different changes that occur in the EKG as ischemia and infarction progresses over time. One of the first things we see in a STEMI is a peaked T wave. This occurs within minutes of ischemia where blood supply to the heart has been decreased or stopped altogether. Within minutes to hours, we begin to see progression of the ST segment being elevated. You can see that the morphology or shape of the ST segment changed into the tombstone shape. The shape of the EKG continues to change over hours and days, the loss of the R wave, Q wave formation, T wave inversion. After days, weeks, and months, you see the T wave becoming normal again, but also see a deep Q wave that continues to persist. One of the ways that you can tell that someone has had a heart attack in the past is when you see a deep Q wave on their EKG. So we talked about what a CAD is, what can happen when a plaque ruptures, and some of the changes that are seen on the EKG when someone is having a STEMI or a non-STEMI. Let's talk about how we treat these things. One of the most common methods of treatment is called PCI, which stands for percutaneous coronary intervention. The groin or the wrist is usually utilized as the entry site. A catheter is threaded up to the heart and the coronary arteries are accessed. PTCA stands for percutaneous transluminal coronary angioplasty, which is just a fancy way of saying we go up through the wrist or the groin up to the heart and deploy a balloon to open the artery back up. Typically, they will also leave a stent in to keep that section of the artery open. So this is what it actually looks like in real life. Let's start with what's going on the left. You can see the contrast dye being injected in an area of pretty severe stenosis of narrowing right here. Now let's look at the right. Again, you can see the contrast dye, and compared to before, blood is able to flow through that section of the artery much more freely. And here are a few more examples of before and after pictures. Another way of treating CAD is with CABG, which stands for coronary artery bypass grafting. This is when you take a section of a vein or artery, commonly from the leg or the arm, and use it to bypass a section of the diseased artery. CABG requires direct access to the heart, which means it's an open heart surgery. It's a lot more invasive than a stent placement or other forms of PCI. When you're reading through previous charts, whether it's the history and physical, a consult note from a cardiologist, or a discharge summary, you may see CABG be documented as a 2V CABG or a 3V CABG. The 2V refers to 2-vessel CABG, meaning the patient has had a double bypass. 3V would be referring to a 3-vessel CABG, meaning the patient has had a triple bypass. Cardiologists have a saying, time is muscle. If a patient is having a heart attack, the longer we let it go without treating it, the more cardiac muscles that will die. So here's a couple of diagrams of how ischemia and infarction advances if coronary occlusion is not treated. The door-to-balloon initiative is a goal that the medical community set for themselves, that in the case of a STEMI, we want to provide PCI within 90 minutes of the patient's arrival to the hospital. That means in less than 90 minutes, we want to stabilize the patient in the ED, get them down to the cath lab, thread a catheter up to their heart, identify the occluded artery, and deploy a balloon to open it back up, then leave a stent in it so it stays open. Things move quickly once a STEMI is identified. Code STEMI will be called, the cath team will be activated, and the STEMI cardiologist will make their way to the ED or cath lab. As scribes, we can help by timestamping things and documenting the calls and consults. If the patient happens to crash, be sure to document the appropriate procedures and critical care time. So we talked about how CAD is treated. Let's talk a little bit about troponin. Again, think back to your biology days when you learned about the thick and thin filaments of the muscle, how actin and myosin slide across one another, and that's how muscles contract. Do you remember learning about how tropomyosin usually blocks the myosin binding sites on the actin filament, but when calcium binds to troponin, it causes a conformation change in the tropomyosin, which reveals the myosin binding sites? When the heart goes without blood or oxygen, such as in the case of a heart attack, heart muscles become ischemic. If left untreated, heart muscles will begin to die, which is called infarction. When heart muscles die, cardiac muscle cells release their contents, including the troponin. Different types of muscles have different types of troponin, and when we talk about troponin in the ED, we're talking about cardiac troponin. We use cardiac troponin as a biomarker looking for evidence of ischemic heart damage. The thing with troponin is that it will take some time, about 3 hours, for its levels to become elevated enough to be detectable in the blood. So if I had a giant heart attack at 10 o'clock this morning, then immediately went to the hospital where I had my blood drawn at 10:15 a.m.,
15 minutes later,
my troponin would return as being normal. There hasn't been enough time for it to become elevated in my blood. But let's say I had a giant heart attack at 10 o'clock this morning, but decided to stay at home, seeing if the chest pain would get better. I finally give up and come into the hospital in the afternoon, where my blood is drawn around 1 p.m.
3 hours later.
In this case, my troponin will come back as being elevated. This is why it's important to ask and document the onset of the patient's chest pain, and this is why we also do serial troponins in the ED. We check the patient's troponin when they first come into the ED to establish a baseline, and about 3 hours later, we check the troponin again to see if there's been a difference. Did it go up, did it stay the same, or did it go down? Troponin level in the blood can continue to increase for a day or two if the heart attack was large enough, and it generally takes a couple of days for it to trend down. Chest pain is one of the most common chief complaints we see in the ED. It would be very unrealistic to admit every single chest pain patient for a thorough cardiac workup. So doctors use risk stratification. One that they like to use for chest pain is called the heart score. It takes into consideration how concerning the story was, what their EKG looked like, the patient's age, the risk factors, and their troponin to come up with a score that can predict how likely the patient will have a major adverse cardiac event in the next 6 weeks. Generally, doctors will use the heart score to rule patients out. For example, you may hear them dictate things like, the patient had a heart score of 0, the plan is to discharge from the ED and to follow up with cardiology as an outpatient next week. Let's move on to ACS. ACS stands for acute coronary syndrome, which is an umbrella term for symptoms resulting from acute coronary occlusion and cardiac ischemia, things like chest pain, shortness of breath, or syncope. It's broken down into ST-elevated ACS and non-ST-elevated ACS. Under ST-elevated ACS, you have STEMI, and under non-ST-elevated ACS, you have NSTEMI and unstable angina. ST-elevated ACS, like the name, includes STEMI, where there are ST elevations on the EKG, and more often than not, positive cardiac markers like the troponin. Non-ST-elevated ACS includes NSTEMI and unstable angina. For an NSTEMI to be diagnosed as an NSTEMI, there are no ST elevations of the EKG, but the patient does have a positive cardiac marker. An unstable angina is when the patient doesn't have ST elevations in their EKG, has a negative cardiac marker, but continues to have chest pains even when they're at rest. Stable angina, which is not part of ACS at all, is when the patient has no ST elevations under EKG, has negative cardiac markers, and has chest pain that gets better with rest. And that's ACS, super straightforward. You will often overhear the docs mention ACS when they're dictating in the MDM something along the lines of rule out ACS, in that they want to make sure that the patient is not having acute coronary syndrome while in the ED. Let's talk about some of the additional workup that can be done to look at the heart. Most of these tests or studies are generally not done in the ED. A coronary CTA is a CT scan with contrast dye which allows visualization of the coronary arteries. On the top left, you can see that there's no stenosis, meaning everything is open and blood is able to flow freely without any obstruction. You can also see how the cross-section is basically a perfect circle. Let's compare that to mild stenosis on the bottom left, where you can see some narrowing of the blood vessel. On the cross-section, you can see how the lumen is smaller and the dark gray area represents the plaque buildup. And on the bottom right, you almost have complete occlusion where there's very minimal blood flow. So that was coronary CTA, and here's cardiac catheterization. Sometimes doctors and patients will refer to these as angiograms. Cardiac catheterizations are a bit more invasive than CTA, as you use the wrist or groin to access the site to thread the catheter up to the heart. Once you're at the coronary arteries, you inject contrast dye, which can be visualized on X-ray. When a patient is having a STEMI and we take them down to the cath lab, they're essentially getting a cardiac catheterization, but in their cases, they're also getting an angioplasty and a stent placement. On Cerner, you'll be able to look up cardiac caths by going to Notes, then going down to Procedure/Operative Notes, then the Procedure Report folder. This patient, for example, had 50% narrowing of the LAD, 50% narrowing of the diagonal branch, and 40% narrowing of the RCA. If you've configured custom filters on your Cerner, these notes should pop up under the normal documentation view. Patients may also go through a cardiac stress test where they walk on a treadmill or pedal on a stationary bike while hooked up to a heart monitor. The idea is that by being on the treadmill or the stationary bike, demand from the heart is increased, and if there are any abnormalities, that will be caught on the heart monitor. In case the patient is unable to walk on the treadmill or be on the stationary bike, they may instead receive a medication that can chemically stress the heart for a similar effect. Sometimes the patients can also go under a nuclear stress test. Using a radioactive tracer that is injected into the bloodstream, myocardial perfusion can be visualized to more accurately identify areas of reduced blood flow. Let's put all of this together. So if a patient with CAD comes into the ED, they may be complaining of things like chest pain, shortness of breath, diaphoresis, nausea, vomiting, dizziness, lightheadedness, palpitations, or syncope. Doctors will often ask the patients to describe the pain. Is it sharp, dull? Is it a pressure or tightness? Or more of a squeezing sensation? Has it been constant since its onset, or has it been intermittent? Does the pain radiate anywhere, or does it stay in one spot? Is the pain worse with exertion, such as walking up the stairs or walking across the hospital parking lot? Is the pain reproducible with palpation, meaning if I press on your chest, is it the same type of pain that you were having? It's also important to document relevant history such as previous MIs, history of cardiac stents or bypasses, other cardiac diseases such as CHF or aortic stenosis, other risk factors such as history of diabetes, tobacco use, or strong family history of CAD. Does the patient have a cardiologist? When was the last time they saw their cardiologist? Have they had any recent cardiac workup such as a cardiac catheterization or a stress test? Generally, anything within the past 5 years will be acceptable. Does the patient take any aspirin? And if the patient came in by EMS, did EMS give any medication such as aspirin, nitroglycerin, or Zofran? Evaluation in the ED will start with an EKG, looking for abnormal electrical activity of the heart, specifically a STEMI. We'll draw blood and check the troponin amongst other things, and a chest x-ray will also be done to rule out other causes of chest pain such as an aortic dissection. Differential diagnosis for chest pain would include things like pulmonary embolism, pneumonia, costochondritis, pneumothorax, and GERD, amongst other things. If the patient is found with the STEMI, code STEMI will be called, which alerts the STEMI cardiologist and activates the cath team. STEMI patients will typically be admitted for a cardiology consult and likely a stent placement in the near future. Unstable angina patients may or may not be admitted, depending on what the patient and the cardiologist decide. So that about covers CAD and ACS. Thanks for sticking with me through the video.